welcome to Vein and Lymphatic University. We have an outstanding faculty day today. Our speaker is Steve Elias, who will speak about a new RF device called Cedar. Steve was the first physician in the USA to utilize this clinically. He will be followed by our discussants, Omar Esponda, Mackey, and Mark Whitley. I'd like to also thank Victor Canada, who is also part of VLU and the president of VLU, who is in the background with the platform. So Steve, please share and take it away.
All right, thank you. Good to be here. Let me share. Okay, this should work out. Let's see. No. Yeah. Do you see it?
Yes.
Okay, good. So let me just go to my presentation mode. All right, good. Everyone sees this, right?
Correct.
Okay, so I'm going to talk to you a little bit about it. It's not that long of a talk. The Cedar catheter, and I think it is another good option. We'll talk about what is it, how does it work, and do I need this? And you may ask, why the name Cedar? The original company that made it was a Chinese company, and they named all their devices after either flowers or trees or something like that. So that's where we got cedar from. It's nothing more exotic than that, and that's fine. I think they're sticking with their theme.
Cedar's a hard wood, though. I mean, a hardy wood. So that's a really good name.
Yeah. All right. So here it is. What it is? It's distributed by Boston Scientific. They bought the rights to it and everything. And it's a radio frequency ablation catheter. It's similar to what we all have now, but again, now it's under Boston rather than being under BD or Medtronic for the other RF devices that are out there in the U.S. There have been some studies done in China, which shows their closure rates are really quite good and comparable to the closure rates that you get with other RF devices. And of course, when you close a great saphenous vein, the VCSS score improves, and here as well. A couple of particulars, and we'll get a little bit into some of the particulars. This is what the device looks like. I'm assuming you can see my mouse arrow. And it fits through a 7 French sheath, and the lengths, it's available in a 7 centimeter heating length and a 3 centimeter heating length. And just like the Medtronic device, there's a half a centimeter overlap between each segment that you treat when you're doing your segmental ablation. So we'll honing in a little bit more on the generator itself. It has a nice screen to it. It's a little bigger than the other devices, which one of us was commenting before this started that they need glasses now all the time. Well, I've needed glasses for a long time, so it's nice that it's a little larger. You have a very nice vision, and you can see all the different components, is what you would expect in terms of the generator. When you plug in the catheter, it tells you what heating length heating length you have there. It tells you how often you've done your cycles. And then time, again, it's 120 seconds, like all the other RF devices. I mean, not 100, you're heating up for to 120 degrees for 20 seconds. And the audible tones for thermal delivery, I'll tell you, just to be honest with everybody, and Boston knew this, when I first heard this, not when I was doing a procedure, but before that, I said, I'm not so sure I like this. But then as you did the procedure, it's actually a very nice, calming, audible tone. So it's a nice sound to it, which you may think is not important, but it is important. The patient's going to hear it, and you're going to be hearing it for a long time. And then there's the ports where you plug in the catheter itself. So again, going down to the catheter comes packaged like this, and we'll talk a little bit more about the catheter. You've got to turn the machine on in the back after you plug it into the power source, of course, and then on the front is where you start it and it then goes through its cycle and is ready for use. Again, similar to everything else that's kind of out there. So honing in on the catheter, its divisions, the heating element here is, as we said, 7 centimeters, or there's a 3 centimeter heating element length as well. And they call this a zebra marked catheter because it's black and white, black and white, black and white. And it does have a lumen that will fit a up to an 025 wire if needed. And there are warning signs, warning bands on the catheter. One is when you're coming to 12.5 centimeters from the second warning band, which is you can see very close to the heating element. So when you see the second warning band, you know that's your last treatment for that patient. And this on the right is showing you the overlap. So it's 7 centimeters in length, but the zebra bands are 6.5 centimeters. So you're overlapping 0.5 centimeter each time. And I know all this sounds familiar to what we have out there already with some of the catheters. Again, this goes a little bit further into what the catheter looks like. These the blue marker bands are really quite important because you want to know when you're getting close to the heating element, and you don't want to burn the skin, of course. The what do you call it? The length of the catheter is 60 centimeters, the entire length of the catheter, and it does also have a retaining ring on the at the end there that you can mark where you started, so that you know what length you're going to be using. It turns on with a little button, which again, all of them have. And this is showing you the first warning band, which is the blue band on here on top of the black mark. And then there's a second warning band, 12.5 centimeters further closer to the heating element. So the first case in the U.S. Was a 68-year-old female. Of course, she had the usual signs of, venous disease. She did have bilateral great saphenous incompetence, and she'd already had a vein-close ablation of the right leg 6 weeks prior. And she was happy with the results. And I told her we're using a new technology similar to what she had, and she was up for it. So this is the pre-treatment scanning, and just a little something. Those of you who have had other people watch you do procedures, maybe not just one visiting doctor, but we had, obviously everybody from Boston Scientific was all around. Just to let you all know, I'm spoiled. You may think I'm a wimp, but from the beginning, I've been doing this in the ambulatory center, and our patients in general get some light intravenous sedation. I'm also spoiled in that I have a vascular technologist helping me. We're talking about from the late 90s when we started doing all this, and I've just kept that up. It doesn't cost me anything because I'm employed by the hospital. So you may think this is overkill, and it is for the great majority of people because things are being done in the office setting, but I'm just letting you know what I do. And you can see here that we have the generator on top of everything else, on top of the laser, the closure fast, the Venclose device as well, the generators. So I wanted to make Boston feel good that they were on top, at least for this day. So we're doing our pre-treatment scanning here, and then we're positioning the catheter. And the positioning of the catheter is, and you see everybody looking in the background. Positioning of the catheter, it's said to be between 2 and 3 centimeters. I just did it at 2.5 centimeters because that is between 2 and 3 centimeters, but you can go 2 or you can go as far as 3. And again, when people are watching you, you want to make sure you do everything right. So it may seem like we're cool, calm, and collected, but in the back of your mind, you're saying, I hope this goes the way it's supposed to go. And here we're doing our treatment. You can notice the black and white markings. Our vascular technologist is actually checking the junction while I'm treating a lower segment down here. And the markings I told you, 6.5 centimeters in length. Device, as I said, is a nice, and you may think this is silly, but it really has a nice color to it, a nice sound to it, and it's nice and bright, which I kind of liked. And you do it in 120 degrees Celsius for 20 seconds. That's what it does. And then we're finishing up. I'm pulling the catheter out and the sheath here, the 7 French sheath as well. And we finished the first case, which went fine. And it does take a team. These are all the people that were watching here. One of the reps you can see, you can't see his head. He's about twice my height. So, I had to get in the picture and we cut him out, I guess. So a summary, it works. I think it works as good as any other radio frequency device. You have the options of different types of lengths of heating elements. I told you it's around between 2 and 3 centimeters from the SFJ and the small saphenous. You'll do the same thing you do for others. I always go to the fascial curve just as it's dipping down towards the popliteal vein, but do whatever you do. The heating cycle is the same as the others, and the inclusion rate in the Chinese study was very good. Most importantly, they did not have any DVTs at all. And just as we've been saying forever, that everyone, physicians need to be comfortable with one thermal and one non-thermal. Now, Boston Scientific has one thermal and one non-thermal as well. And I think all industry needs to have one thermal and non-thermal they can offer to their customers. So that is the end of the talk. Let me stop my share. All right. We're back, right? Lowell, you're on mute.
I'm not on mute. I just
Now you're
can't.
not. Sorry, I see.
No worries. I'm not mute. But anyway, thank you for that presentation. I do have a couple of questions before I turn it over to our discussants. In the kit itself, what comes in the kit?
Yeah, the kit that was handed to me is just the catheter itself. There's no sheath within the kit at all.
Or access, right?
No access, right? No micropuncture sheath, no 7 French sheath. That was not in what was handed to me. I don't know if their plan is to package that. Remember, they were just bringing the catheter to me. I told them I had everything else that I needed.
Right. So the sheath that you used was the length?
I used a micropuncture, and
No,
I used
like
a short 7 French.
Okay. Does that go along with the markings?
Does that yeah.
Okay. Omar, floor is yours. Thank you, Steve.
Sure.
Dr. Elias, how you doing, sir?
Sure.
Question. Is there a reason to look at what's administered, or do you go by cycles after every 20 seconds in the application of energy?
What do you mean? Oh, the energy itself? No, the device itself self-regulates itself to give you the energy that it needs, as do the other RF devices. It's not like a laser where, yes, you want to monitor how many joules per centimeter you're giving with your pullback rate and the number of the amount of energy you're using. But no, this is a self-regulating device that's going to give you the temperature that you're supposed to get.
And is there a time limit in the lifetime of the catheter after you deploy it first? How many cycles can you do in one sitting? Or is it a time because of a battery, such as maybe like the Venclose device?
No,
it is time limit.
They did not tell me any time limit at all, and I don't think there is a time limit to the device itself.
Thank you, Omar. Let's move on to Ed Mackey.
Oh, well, it does sound very similar to the original Medtronic's catheter. Nothing doesn't sound like there's, from what you said, that there's anything really new to this, which is fine. I imagine it's going to work well. As far as monitoring energy, I've always kind of tried to watch the energy in my Medtronics, make sure the watts do drop, down to a level that I feel like is closed. I don't know if you have to do it. You have to. I haven't done any studies to really determine that. I call it the Tokyo protocol because there was a Japanese doctor that visited me, said that, 12 watts in the old Medtronic's catheter, when he did testing on liver, left a char, and the char is what he thinks we're going for. But I don't know. But no one's done a real good study that has really answered that question. I know. Then I call it the LA protocol. What's this? Peter. Oh gosh, what's the guy from
Peter Lawrence?
Lawrence, yeah, the Lawrence protocol, Peter, yeah, where he does double treatments all the way down, and he's felt like that gets you up from that 98% to maybe a little higher,
Yeah, no, I should say in general, Ed, I do double treatments all the way to the knee. And
Okay.
then when I get to the knee or below the knee, I do one because I want to minimize some injury to the saphenous nerve. But yes, with all of the RF catheters, I do double treatment to the knee level. I know the IFU doesn't say you need to do it, but so it's another 20 seconds times 3 or 4. What's the big deal?
So in Venclose, they do actually have in their IFU measured by the diameter, and they can go up to 3 cycles depending upon the size of it. And you and I and everybody else on this knows that we could also use tumescent to close that vein, because RF needs certainly conduction, where laser is convection, conduction, and radiation. So it has to be coapted there. Ed, thank you for bringing up that comment about the protocol in terms of the amount. I have followed your protocol or wherever, but I think it depends on the particular piece of equipment that you're utilizing. I'm going to turn it back over to Mark Whitley, please. Very experienced in most modalities, like all of us that are discussing.
Thanks very much, Lowell. Steve, I was just going to just ask about, I assume when you say it's 7 centimeters and 3 centimeters, that's 2 separate catheters, is it?
Yeah, 2 separate catheters, right. It's not, you can't toggle between one or the other.
No, I always wish that one of these devices would have like a 1 centimeter tip, because the one of the other catheters, sort of, as you know, it's got a 2.5 centimeter. And I think if you're doing either perforators or you're doing small sections of neovascular tissue, anything a bit more advanced, I think a much shorter end would also help. But
Yeah.
I don't know if you've got any influence for a grade 2 for the Cedar. If you could, and tip them into a 1 centimeter end, that would be quite helpful, I think.
Actually, Mark, the Venclose Maven actually has a 0.5 millimeter, and that's used for perforators. But yeah, but it's a separate catheter, and it's called Maven. But yes, good idea. I like the fact that you can toggle back and forth, so you don't have to have a number of SKUs in your office in terms of that. And I think, Boston, this is entry for them. They understand all of this. So I look forward to their development with this Cedar.
Yeah. And they're listening to all of us as to what we might want. And this is, the first, as Lowell said, iteration of this device. They already have plans for their second iteration, and their R&D guys are tweaking it and listening to all of us as to what we think we want out of a catheter. I mean, I don't want anyone to get the impression that I think being as good is good. I don't think this is like so much better or so much different than what we have already, but it's nice, as I said, that I think every company needs a thermal and a non-thermal, and there is still one company that doesn't have that, but maybe they'll wind up listening to all of us and adding that to their kit that they sell to their people. But yeah, I think the thing is it works, and It was no different than any of the others. We did 3 cases that day, and they all went exactly the way that you think they should go. And I've seen all the patients obviously since then, and they're all occluded, and everybody said I had minimal pain, just like any other RF device, and I got back to work that next day, or I got back to doing whatever I wanted to do. So post-procedure patients are going the same route as any other RF we have, which again is good.
I have a question from Professor Bozkurt from Turkey, and he's saying still 2.5 centimeters distance. I was hoping with a new device, a safer tip, we could be closer to the junction like they are doing with laser.
Laser, right. Yeah. I mean, clinically, personally, I don't think it makes a difference. I know there's those people who feel you got to get as close as possible. I don't know what everybody else thinks about it. I'm pretty happy with the results of the patients and the decreased risk of the minimal DVT. So, you got to weigh one or the other. Everybody else, what do you think about? Do we need an RF device?
To be perfectly honest, Steve, I didn't know any better in 1999 when I did RF, which was a continuous pullback. I started right at the junction, and whether I looked or not for endothermal heat-induced thrombosis, I don't remember, but we didn't have any problems. So, but then with E-hit and everybody talking about it, and I'm not sure, in my opinion, that an E-hit 2 matters anymore because of the bulk. So maybe we should be looking at going forward to that area. So just a comment. Mark, Ed, Omar on that?
Yeah. Can I just say with that, I always think that you should just not have eddy currents, because that's where you can get thrombosis. And I think, you go to a junction. So either you can go right to the junction if it's swollen if you want to, but my preference has always been I find this superior inferior epigastric vein and I close there. So I just get a wash through of the end. And because of that, we see very little E-hit. I think what you don't want is just any blind ending sacs. And this catheter, you'll be able to do that with a good ultrasound. I was just going to ask Steve, just one other question, just so, because I've got to go in a minute, but I was just asking, do you put the patient head down as well, or do you just use tumescence?
I just have them supine. I think we're so good at tumescence nowadays that we don't need to put them in, Trendelenburg position. It's nothing bad about it. And I certainly think sometimes for the patients that are being done awake, remember mine, get a little sedation. I think supine is a little more comfortable than having your head down and you're already anxious and blood rushing to your head. I mean, we did it in the beginning. We pressed on you remember this, Mark. We pressed on the course of the vein because we just were not as good with tumescence as we are now. And we wanted to make sure we had contact with the vein.
Thank you.
Ed, final comment?
Well, I just think competition's good. I mean, it was amazing what happened when Vin closed into the market, how much Medtronics dropped their price. And no, I'm happy to see more entering the market. It just, it really does make a dramatic difference in prices when you have a couple of them fighting for your business. And now there's 3. There's 3
If
or
we
more.
if we do this right, if we get more, and maybe they'll be paying us to do the procedure.
Yeah. I'll add that, and I think I've told below this. There's a company that sells angioplasty balloons and catheters. I'm trying to think of the name. But it's something Catheter Direct. No, I forget the name of it. But they've been advertising in the emails that they have a RF catheter. And let me tell you, they have 1 centimeter, 3 centimeters, 7 centimeters. They have 6 French, 7 Frenches, and all kinds of stuff. I don't know much about it. I haven't used it. And then, of course, I told them there's a Korean company that's entering the market. So, I mean, I think this is only good for us. And, whether there's going to, as far as hopefully, competition, and then we'll have to determine if there's really any benefit to any one or particular one, but I don't think there's going to be a lot.
No.
And I think the number that you were talking about in terms of different catheters may be used for oncology, 1 centimeter, 3 centimeters, 7 centimeters. But I think this is interesting. Steve, I'm going to ask you a question. We've talked all about RF today. Do you see any I mean, when do you use laser? When do you use RF? Because I know
Yeah.
you've used both.
Yeah. I tend to use laser in two circumstances. In general, RF is my go-to for a thermal. But I tend to use laser if the vein is, 12, 14 millimeters in diameter, a really big vein, because then
Side,
obviously, what? Yeah,
eyes.
you could, you can do your pullback slower. You can give some more joules per centimeter and stuff like that. And I like laser a lot for perforating veins as well, much better than the RF devices. So that's really where I feel laser fits in. And again, some people do laser all the time and patients do fine. I just think people are a little more tender after a laser procedure than they are after RF.
So who do you use for short segments as well, laser? Because you don't need as much running room.
Anybody?
Can you
I
hear me?
I use laser for everything for that point, because you can get everything from, a small perforator bit neovascular right to the longest thing. But you're right, Steve. I think you do get more pain, obviously, depending on your joules and wattage. But the one thing I always worry about with the segmental RFs rather than the old sort of bipolars or monopolars is just that when you've got a big vein, and certainly in our practice, we published a paper that 18% of our patients are over 15 millimeters. And so, like with all of these discussions, it always, when we end up arguing, sometimes it's because we've just got different populations.
Yeah.
It's really kind of interesting that we talk about size still, when we know the thickness of the wall is really kind of important. And in radio frequency, the fact of contact is important. Linus, you had a question, but I didn't understand it.
Yeah. Okay. It's a question for Steve. What you choose in case of short stumps in case of recurrency?
You're talking about like neovascularization and stuff?
Yeah, it's if you have 2-3 centimeters stump in the groin or in popliteal area, what technology you choose?
Well, as Mark said, you can use laser if you want. Or sometimes in those, if they're really short and the varicosities are coming from them, there's another device that hopefully you'll be able to use soon, a device that will ligate it. But I may sometimes make a small incision, just openly ligate that short little segment if it's not amenable to laser. And by the same token, I mean, we can have a whole theoretical discussion about this, but do we always need to treat a 2-3 centimeter stump, or should we just treat the varicosities themselves?
Treat the patient.
Right.
Anyway, I'm going to end this. So next week on February 18th, Dr. Luca Palumbi will be speaking about the preliminary results for the TOTEM trial, total endovenous laser ablation. You will be joined by Dr. Zapansky and Linus. So we look forward to that. Thank you, everybody. Thank you, Steve, Mark, Ed, and Omar. Appreciate your time. Have a good day.